Welcome everyone. A second, yeah, just set up this thing. We shall start probably, yeah. I think welcome everyone. We have at least 27 attendees at the moment. I think slowly more will be coming, but we try to start on time. Right. Welcome everyone. Assalamualaikum and a very good afternoon. On behalf of the College of Ophthalmologists, me, Dr. Musha, would like to welcome everyone for joining us today. This is actually one of our webinar session from the Retina chapter, which is led by Prof. Melin. She can't be with us today as she is in Bali at the moment. So as we know now, today we have our esteemed speaker, Professor Lim Lik Thai, as our honorary guest speaker, who will be sharing on the important topic of diabetic retinopathy. Thank you, Prof. Lim, for being with us. We are privileged to have Prof. Lim, and he will guide us through the intricacies of diabetic retinopathy from fundamental to the latest development in the treatment. But before that, Prof. Lim, allow me just to introduce you to the speakers. Of course, Prof. Lim Lik Thai do not need much of introduction, but still allow me to briefly share the summary of his long impressive CV. So Prof. Lim graduated from the Queen's University of Belfast, UK, with multiple academic awards, completed postgraduate training in the UK, as well as the fellowship training in glaucoma and vitreoretina in 2015. And Prof. Lim is also an active researcher, published more than 80 articles in various peer-reviewed journals, as well as chapters in the book. Prof. Lim also leads many retina-related research grants, and we are fortunate to have you, Prof. Lim, to be with us today. Thank you. Let us not waste our time. But before that, allow me just to remind the audience, if you have any questions, feel free to type in the chat. We will probably answer that towards the end of the session. Probably take all the questions, yeah? So over to you, Prof. Lim. Thank you.
Thank you, Dr. Musha, for the kind introduction. And I'm just going to share screen and let's start now. Okay, share screen. Okay, so here we go. Okay. Where's my mouse? Here. Okay. Can everyone hear me?
Yes, Prof. Lim.
Okay. I'm just going to get the slideshow. Okay, here we go. Okay, a very good afternoon to everyone. And here today, I would like to share with you on the topic of diabetic eye disease. So here's my declaration of interest. I have nothing to declare. So let's start with diabetes, introduction of diabetes. Basically, it can be broadly divided into type 1, which is insufficient insulin, and type 2, insulin resistance. More so, they have type 2 diabetes compared to type 1. And it's a very common condition with lifelong implication in systemic. Let's get out of the way. Okay, I think that's better. Yeah. So yeah, we shall focus more on the type 2 because that's a more common one. So it has lifelong implication and is multi-systemic and multidisciplinary management. Of course, there's a financial and economic implication on the individual, family, and the nation as well. And lifestyle issues, accessibility to optimal healthcare, and one of the leading causes of visual debilitation among working age adults in the world. So basically what it means is that this diabetes actually impact on all levels from individual up to nation and international level. So basically, diabetes is a systemic disease which can affect multiple organs, including the eyes. And in fact, diabetic eye disease itself have multiple segments of the eyes can be affected. And this session is hoped to enhance the awareness and appreciation of the diabetic eye disease, the challenges and considerations in its practical management. So here we are going to discuss more on a practical level as well, so that you can, use this in your daily practice. And at the end of the session, the audience is encouraged to participate in active discussion and exchange of knowledge to enhance the patient care in the future. So let's start with the demographics. So back in 2015, this is the source from the International Diabetes Foundation. Back in 2015, adult population is 19.887 million, of which 16.6% have diabetes. And the number of deaths due to diabetes is 34,500 over in 2015. And the cost per person with diabetes mellitus is $565 per year. That's the average. And total cases of adults with diabetes, 2015 is 3.3 million. Estimated number of undiagnosed diabetes in adults is 1.7 million. So that was back in 2015. In 2021, this population has increased 22.13 million. The prevalence of diabetes have also increased to 20%. Total case of adults with diabetes now 4.4 million. You can imagine not just the number has increased, but also the percentage has increased. In fact, Malaysia is the world's top diabetic patient by ratio. So this is just to illustrate to you the comparing demographics with Asian region. In 2021, you can see that Malaysia tops the prevalence in adult in 20%, whereas our neighboring countries are far lesser, with Singapore 14.9, Thailand 11, Indonesia 10, China 13, Japan 11, and Philippines is even less than 10. So, and this here is just a graph to illustrate how much more diabetes by ratio Malaysia is compared to the world average in this 2015 graph. So the importance of management of diabetic eye disease cannot be stressed enough, because it affects, like I say, all levels. First of all, the quality of life, personal and family. So if you imagine someone who can, because of diabetes problem, cannot see, cannot walk, etc., it's going to be a personal burden to the person. The person may not be able to work, and it's going to be a burden to the family as well, because the family needs to look after the person. And from an economic standpoint, because a significant proportion of diabetic patients are in the working age category. So if the patients in this category has been debilitated due to diabetes, so they are not able to contribute to their work and hence not able to contribute effectively to the economy. And from a public health perspective, in Malaysia, the Ministry of Health is a major healthcare provider with a limited budget from the Malaysian government. So if diabetes patients keep increasing, so there's a need for more budget for this. So this would mean that our public health may be constrained as well. So with that in mind, I think it's very important that diabetes as a whole needs to be well looked after with the active participation from the patient themselves. So here, just to go through the risk factors of diabetes mellitus, the major ones being unhealthy lifestyle, obesity, aging, genetic susceptibility, and sometimes even the use of medications like corticosteroids. So here, diabetic eye disease, I would like to think of it in terms of diabetic retinopathy, diabetic maculopathy, and the miscellaneous, including papillitis, refractive changes, rubeosis. But of course, the more common one are the diabetic retinopathy and diabetic maculopathy, which we will look into a bit more, because these are the main sector that actually contributes towards visual problems. So here's just something to refresh our memory on diabetes mellitus pathogenesis. So this picture here represents the normal physiology, whereby the insulin enters the bloodstream from the pancreas, leaves the bloodstream to the binds to the cell, and the glucose enters the bloodstream from the digestive system and the liver, and in response to the insulin, uptake of glucose happens to the cell. And there's a healthy balance of glucose and insulin circulating in the bloodstream. That is what nature intends this to be. However, in the diabetic patients, in type 1 diabetes, there's insufficient of insulin. So the insulin is there, but it is not enough for the body to use. And therefore, we have a diminished glucose uptake and hence increased blood sugar level. Whereas in type 2, which is a much more common problem, especially in our parts of the world, is insulin resistance. So the insulin is there, but it is not responsive enough so that the glucose intake, the glucose uptake will be diminished. So here is a busy slide, but of pathogenesis for type 2 diabetes mellitus. So basically, I just like to draw your attention to three things. I don't know whether you can see my mouse cursor. So basically, the first type is the genetic susceptibility. So, well, we are born with it, no choice. And the second part here is actually the vicious cycle here of hyperglycemia, causing glucotoxicity, which will then cause hyperglycemia, directly having this toxic effect on the beta cells. And with that, over many years, insulin resistance will become worsened, beta cells will tire out and reduce insulin secretion, and they have insulin deficiency at the later stage. And also to highlight the other part of the pathogenesis is the lipotoxicity. So the free fatty acids inhibits the function of the GLUT2 receptors on the beta cells, therefore reducing the glucose import. And the beta cells do not recognize high blood glucose, therefore reduce insulin secretion, and again create a vicious cycle whereby over many years, as the insulin resistance worsens, the beta cells tire out, reducing the insulin secretion. And in here, since the cells can't use the glucose, body perceives a state of starvation, thereby mobilizing the triglycerides into the free fatty acids to be used as fuel by the cells. But this free fatty acids is toxic and therefore inhibits the function of the GLUT2. So it's a vicious cycle there as well. So that is the reason, that is the pathogenesis. And how does it affect the eye? Translating the systemic pathogenesis into how it affects the eye. Well, this is a highly complex interconnected network of mechanisms, but in brief, it is because chronic hyperglycemia results in activation of alternative glucose metabolism pathways, multiples of them, leading to activation of cytokines and growth factors, resulting in vascular endothelial dysfunction, vascular permeability increases, and microvascular occlusion. The microvascular occlusion causes ischemic process leading to the formation of intraretinal microvascular abnormalities known as ERMAs and neovascularization. So now, with that in mind, with this pathophysiology, how does it lead to clinical changes? Well, because of the pathogenesis that we discussed, there will be leaking capillaries leading to macular edema, capillaries occlusion leading to ischemic macula and retina. And the ischemia itself will lead to neovascularization, which further lead to vitreous hemorrhage and tractional retinal detachment and rubeosis and rubeotic glaucoma. And also because of the fluctuating osmolarity, cataract can actually occur as well at a faster pace. Oh, sorry. I actually skipped one slide. So basically, just is to highlight to you the various major alternative glucose metabolism pathways that is being in play. One of them is polyol pathway, which produces the sorbitol, causing cellular osmotic damage. It promotes also the formation of advanced glycation end products known as AGEs, which can weaken the microvascular walls and loss of pericytes and promotes pro-inflammatory cascades. The protein kinase C activation also leads to expression of stress-related proteins and inflammation. And the poly-ADP ribose polymerase activation contribute to DNA damage and endothelial cell dysfunction in diabetic blood vessels. All these can lead to oxidative stress, which can affect angiogenesis and cell death as well. So now that we have gone through the pathogenesis and how it affects the eye, so let's go on to the more practical clinical aspect of the diabetic eye. So first of all, patient history taking. Now, patient history taking is very important here. For various reasons, we need information to assess the patient's condition, assess the patient's not just the eye condition, but also the systemic condition as well as the social condition of the patient. So we see the patient holistically, manage the patient holistically. And in terms of ocular history, well, things like asking about blurring vision, fluctuating vision. So fluctuating vision, for example, if you have cataract and with poorly controlled diabetes, fluctuating osmolarity, you can get the waxing and waning of the vision because of the different levels of fluid inside the natural lens. And blurry vision can be from many reasons, which we are going to talk about a little bit more detail later. And of course, we have asked about floaters and visual field defects. For example, if someone has a fractional retinal detachment, may have visual field defects, and also other eye issues that may be related to the diabetic eye. For example, glaucoma, any previous laser treatment, eye surgery before, is all giving us a better idea of the state of the eye as we are managing it. And then we also need to know regarding the systemic history as well. It's important to note or to ask the patient on the diabetes control, how is it? And one of the ways that we can actually gauge it is by asking the patient if they know their latest HbA1c level, and that will give us a better idea of the systemic control over the last 3 months, which may be even better information compared to them keep giving you a diary of their daily BM levels. And of course, we need to know the duration of the eye of the diabetes, and any associated comorbidities such as hypertension, dyslipidemia, and any medication like steroids, any previous procedures done like cardiac procedures, amputation, any dialysis, neuropathy, those and stroke history, and those are basically giving us a better idea of the patient's general health condition in relation to the diabetes as well. And also for the ladies of childbearing age, to ask about pregnancy as well, because some patients, although these are rare, some patients during the pregnancy or even after just immediately after the pregnancy, for some unknown reason, their diabetic retinopathy worsened to a point where it fibers up very quickly, vitreous hemorrhage, etc., and leading to poor vision with poor prognosis. So all these we need to really look into, and also to inquire with our patients regarding their physician input on the diabetic care as well. It's basically we are working as a team here for the patient care. So we have to ask our patient regarding their physician's input as well in the matter, how well, whether they are frequently visiting their physician as well to have the diabetes controlled, etc., etc. All these are very important. And on the social history front, occupation, family support, community support, personal circumstances, all those are very important. And also the ability of the patient to access healthcare facilities as well. Some patients may be too busy, they don't really care about their appointments, etc., etc. So all these will give us a better idea or understanding of how the patient perceive their control of diabetes or perceive, the importance of the control of diabetes. And of course, ethnicity, smoking, just to highlight a few important points here in the history taking. And okay, here I'd like to stress that the ocular and systemic control of the diabetes are really important. Although as ophthalmologists, we treat eye disease, but at the same time, we need to pay attention to the systemic part as well, because this is really like a cause and effect thing, and the root cause is suboptimal control of the diabetes itself, which is a systemic issues that need to be well addressed. And therefore, we need to encourage the patient to have a good systemic control and the need to work closely with the physician diabetologist, whether one is working in the government sector or in the private sector, is equally important. I know that sometimes in a busy clinic, things might be, time is the essence, and you might feel that it's a rush here and there. Just tell the patient, go and see your physician. Sometimes when we are concerned of the patient condition, we would prefer to write a referral letter or a letter to let the patient give to their physician to show how serious the situation is and need, so that the physician, when they see this, will be more aware and more on board in treating the patient. And finally, also empowering the patient themselves in patient education so that they are more aware of their condition and appreciate the importance of control of the diabetes in collaboration with the physician and diabetologist. Here is just to give you systemic points here on the landmark study as to why systemic control is important, even for the eye. So with the type 1 diabetes, we have the support from the Diabetes Control and Complications Trial, which shows that type control was associated with 76% reduction in retinopathy, 60% reduction in neuropathy, and 54% reduction in nephropathy. And the UK PDS study, which is mainly for type 2 diabetes, showed that the type control was associated with a 25% reduction in microvascular disease and with tighter blood pressure control associated with 37% reduction in microvascular disease and 32% reduction in diabetes-related death. As diabetes can occur with other comorbidities, any ocular symptoms must be carefully managed. Yeah, meaning to say, sometimes the visual symptoms may not just be attributable to diabetes, but also a multifactorial, for example, hypertension, giving rise to, say, for example, vein occlusion, artery occlusion, and for example, neovascularization of the iris, uveitis, or might be thinking of ocular ischemic syndrome, checking for carotid bruits, things like that. So these are just some considerations from the history of the patient with diabetes. So fluctuation of blurry vision could be due to possible suboptimal glucose control with fluctuating osmolarity affecting the natural lens. If it is blurry vision, painless, suddenly happen, possibly could be due to vitreous hemorrhage, retinal vein or artery occlusion, or non-arthritic anterior ischemic optic neuropathy. And those with gradual blurry vision, painless, possibly cataract, macular edema, ischemia, tractional retinal detachment, and diabetic papillopathy, which is a diagnosis of exclusion. So, and then we go on to the blurry vision with pain or headache, which can be ocular ischemic syndrome, arthritic anterior ischemic optic neuropathy, giant cell arthritis, or even the severe rubeotic glaucoma. So the history itself is very important when we take, especially the visual symptoms, because as we know, diabetes affect vision. So that's the most important, crucial history to take. Okay, so after the history taking comes the ocular examination. So of course, like anything ophthalmic related, the first thing you need to do is check the visual acuity, full visual acuity, and then after that you look and observe the patient, looking for any other, general signs and also facial signs of any neurological signs, etc., etc. Then we can go on to slit lamp examination. In the anterior segment, we look for things, actively looking for things really, because sometimes if you don't actively look for it, it's staring in front of you, you won't see it. So that's why we have to actively look for these things. So these important things include rubeosis, cataract, cells in the anterior chamber, hyphema, high pressure check. And posterior segment, dilated fundus examination, we look for the vitreous cells, red blood cells, features of the diabetic retinopathy, and grading the stage accurately. And diabetic maculopathy, the edema, the thickening, and the optic disc needs to be observed and documented. And of course, if rubeotic is seen, one may also consider checking for carotid bruits. And here I would like to share another idea, the role of ultra-wide field fundus photography to further enhance the documentation and assessment of the fundus. Although I can understand and appreciate that not every center will have this facility because of the cost of it, and sometimes it can be time-consuming. But nevertheless, ultra-wide field fundus photography can actually enhance the documentation and the assessment of the fundus. Because sometimes we might miss something that may have been picked up as well by the ultra-wide field. This is just an example to illustrate to you the normal fundus image and that of the ultra-wide field. The one on the left is the normal image. The one on the right is the ultra-wide field, showing that more information can be obtained. And of course, this ultra-wide field fundus image can be enlarged as well to view it more accurately. So that is one of the things. So now approach to diabetic eye disease. So we're mainly focusing on the retina, but also managing associated eye issues such as cataract and rubeotic glaucoma. So here, when we are documenting our clinical findings, the stages of diabetic retinopathy need to be properly documented. Yeah. The stages of diabetic retinopathy here, we have to note that it may be independent of the diabetic maculopathy, meaning to say you may have not so severe diabetic retinopathy, but you may have quite a significant diabetic maculopathy and vice versa. So classifications, ideally we use widely used or accepted classification, for example, the Early-House classification as used in the EDTRS. One of the reasons for a uniform use of a more detailed classification is a more accurate documentation of severity, which carries the same meaning across the board. For example, when you are communicating with your colleagues and you use this classification, so everybody knows exactly what it entails and everybody's on the same page. And secondly, it can also be a uniformity in research data as well. So this is just able to illustrate the classification that's widely used, divided into 4: mild non-proliferative diabetic retinopathy with micro aneurysms only, and moderate non-proliferative diabetic retinopathy with at least one hemorrhage or microaneurysms, and or at least one of the following: retinal hemorrhages, heart exudates, cottonwool spots, or venous bleeding. And in severe non-proliferative diabetic retinopathy is the 4-2-1 rule, whereby about over 20 intraretinal hemorrhages in each of the 4 quadrants, or definite venous bleeding in 2 or more quadrants, or prominent ermas in 1 or more quadrants. And of course, the proliferative diabetic retinopathy is as long as you see new vessels or vitreous hemorrhage. So sometimes you see vitreous hemorrhage in diabetic, is always proliferative diabetic retinopathy until proven otherwise. This here is just an example of the different stages of the diabetic retinopathy. As you can see and appreciate that retinopathy and maculopathy happens with varying severity in the same person. And yeah, so after we have assessed the retinopathy, now is to assess diabetic maculopathy. So basically, we are looking for changes in the clinical changes in the diabetic maculopathy. Things like focal areas of leakage, such as exudates surrounding the microaneurysms and macular edema, or sometimes you have a diffuse leakage and edema, and sometimes you can even see featureless or pale-looking areas with attenuated or ghost retinal vessels indicative of ischemic maculopathy. Sometimes it's a combination of the above. And regarding the clinical assessment of the macular edema, CSMO stands for clinically significant macular edema. So the definition is a retinal thickening within 500 microns from the fovea, or hard exudates within 500 microns of fovea associated with adjacent retina thickening, or retina thickening more than 1 disc area, any part of which is within the 1 disc diameter of the fovea. So with that in mind, I'll just give you an example. So this is just an example of the maculopathy. So this is not a full picture, it's just mainly on the macula. Let me see. At this point, I don't know whether any one of you would like to comment anything on this picture. Maybe you can unmute yourself and, share your thoughts.
Anyone would like to answer to Prof. Lim? Is there any I believe there's a few master students in the anyone wants to or even you can actually type in the chat. Is that correct? Probably then we can also accept.
Yeah. Let me
answers.
see if I can see the
Yeah.
see the chat or not. Let me see. I think I can see the chat. So far, nobody is typing anything yet. So I'll try to. I'm trying to make this as interactive as possible. So yeah.
Candice, do you want to type anything so that we can learn? Yes, nice. Okay. Thank you, Mama Izzat.
Okay.
Dr. Izzat, yes, thank you.
Yeah. Anything in particular that you can see? Okay, I'll just bring this up again. Anything in particular that you can see that striking features here? So basically, this one you can see is although this is a partial picture, but you can see that although it's a 2D image, so you won't be able to see whether there's any macular edema or not, unfortunately. But you can see that this is actually, you can see a lot of not just dot hemorrhages, but also blood hemorrhages, not just within the macula, within the arcade, but outside the arcade as well. So you can see how serious the condition is. And looking at the tortuous vessels as well. And yes, you can see exudates as well. Yeah, and also microaneurysms and also blood hemorrhages on the macular region as well. So this is actually quite a fully controlled diabetic patient with You can see all these blood hemorrhages, things like that. It's quite indicative of ischemia. So let's move on to another picture. Let me see. Where am I now? Okay. So this is the second picture of mainly of the macula, but you can see the periphery retina a bit. So what do you think of this one?
Thank you, Dr. Jan. Lim also answering just now. Anybody else would like to answer in the chat? Probably easy to answer in the chat.
Yep. There's multiple heart exudates with succinate rings, yeah. And you can see there's a lot of blood hemorrhages around as well. So if you were to extrapolate, you might say that there are 4 quadrants, about 20 or maybe more than 20 microaneurysms and blood hemorrhages in the 4 quadrants, which signifies severe non-proliferative diabetic retinopathy. So to highlight to you, you can see multiple succinate exudates, multiple sizes you can see here. These are all multiple succinate, see smaller, bigger rings all around. As you can see, even here there is all this around. And to note that within the each succinate ring, you will see dot blood hemorrhage as well. Yeah, so this is where the leakage are. So if you have to laser, you will laser on these microaneurysm or the leakage area here. Focal laser, with laser, to do that, not to go too near to the fovea. Yeah. Okay, so let's move on. Okay, now the role of OCT in the assessment of the macula. So in the past, when we do the checking of the clinical examination of the macula, we just document, is there any thickening, any CSMO, where are the part exudates, etc. Now, with this advancement of technology, we have OCT as well as OCTA to help us not just in diagnosis, monitoring, also assessment of the diabetic maculopathy. In most centers nowadays, we have OCT, but not as many having OCTA. So OCT here is actually becoming more like something that we really rely on these days in the management of diabetic maculopathy. It not only supports the diagnosis, monitor the progress of treatment, but may also have value in the prognostic and predictive aspect of the maculopathy, and hence may influence the management plan. And OCTA also further reveal areas of capillary dropout as well. I think Professor Naina actually gave a talk recently on OCT, so I think you are quite well aware of OCT. So we'll move on from here. So I'll just introduce you to the OCT in diabetic macular edema and the biomarkers, prognostic biomarkers. And basically, one of the most important one is the integrity of the photoreceptors, the ellipsoid zone, and the external limiting membrane. And if it's not intact, of course, the prognosis is not as good. And also the disorganization of retinal inner layer drill by the axons to axons connection are not intact. And this has been known to have poor response to anti-VEGF treatment. So this is just a picture to illustrate, it's a labeled picture to illustrate where the ellipsoid zone is, the outer segment photoreceptors is, all this thing is. And you see that this part that has been circled in red, disrupted area, you can see the integrity of this ellipsoid zone and photoreceptors no longer there. So it's one of the OCT features in diabetic maculopathy that you need to to note and take on board and to document it in your notes as one of the prognostic factors. Yeah, and this second one here is the drill. Okay, basically this one is defined as a boundary between the ganglion cell, inner plexiform layer complex, inner nuclear layer, and outer plexiform layer, which could not be identified. So you can see on your left side, you can see the layers here, as mentioned there, is like a blur. You could not even see which is which and what is what. And this here is another picture. This here is another example. The middle column and the right column, they are of the same patient. But it's just to highlight to you that if you take this 1 millimeter segment here, you will see that these red dots here represent normal lines, yeah? Whereas this here represents disrupted structure, which is in keeping with drill. Yeah. So all this needs to be documented as well. And the size of the cyst here also needs to be documented. Okay, so now let's go on to OCT. Now this one is the predictive biomarker. Just now it was a prognostic biomarker, and now you have the predictive biomarker. So predicting whether this is this case is having a expected good response to treatment, anti-VEGF treatment, for example. So one of them is the hyperreflective foci, and a high amount of that is not favorable treatment outcome is to be expected. The hyperrefractive foci marker is a marker of increased inflammatory state. So studies have shown that patients with increased amount of hyperreflective foci have an increased level of CD14 and interleukin-6, for example. And high amount of HRF we can expect poor response to anti-VEGF as well. Now, in a lot of literatures, we might claim that the HRF is only in certain layers, i.e. the outer plexiform layer, but recent studies have shown that in diabetes, this hyperreflective foci can be found in all layers of the retina. And it can be differentiated from the hard exudates by the lack of backshadowing and do not have any representative visible fundus lesion as well. And how do we differentiate from the blood vessels? Is by the size, because this is less than 30 microns, and it's also lack backshadowing. So this here is just an example of hyperreflective foci. So you can see this example here. The figure A shows the raw OCT scan, whereas picture B highlights to you where the major hyperreflective foci are. Of course, having said that, if you look at this carefully, you can see at different layers, you would see also the hyperreflective foci. Okay, so this is just how it would look like on OCT, and you can document that in your notes if you see a patient with OCT, diabetic maculopathy with these things. So this is one of the. Okay, and what are the other predictive biomarker in the OCT for diabetic maculopathy? The other one is a large cyst of more than 250 microns, which is associated with chronic diabetic macular edema. But in this kind of situation, many of these patients may have a favorable response to intravitreal steroids like Ozurdex, for example. DRIL can also be a predictive biomarker as well, and also subretinal fluid, which is associated with increased inflammatory cytokines. Okay, so here, let me see if I can get this. This is just an example of OCTA. It's just to highlight to you the usefulness of OCTA, and it will give us a better idea of the perfusion in the macular area, papillary perfusion. So the one on your right, sorry, on your left, labeled as A, is normal perfusion, whereas that of B is that of an ischemic area where you can see an increase in this foveal avascular zone, and also capillary dropouts areas. You can see, compare that to this. Oh, sorry, wait 1 second. Compare the one on your left. You can see all these, there's no dark areas of dropouts, whereas in the B, you can see dark areas of dropout, capillary shutdown, and wider area of foveal avascular zone. So this is telling you of ischemia. And if you have the OCTA in your clinical practice, you can also document this in the patient's notes, basically giving us more information on the state of the maculopathy. So this here is another patient. You'll see that we can correlate the clinical pictures, that of the fundus fluorescent angiogram, as well as the OCTA. So you can see here in OCTA whether it is deep or superficial. You will see the areas of capillary dropouts and areas of ischemia as well. Sometimes you need to correlate the clinical findings with that of the OCTA to give a better picture. So after the clinical assessment, now we are going to the management of the disease itself. So the general aim is to manage the root cause, obviously. The diabetes mellitus, working together with the physician and diabetologist, we really need a control. Basically, not just a good control, but the key here is good and consistent control. The reason is because if the diabetes is one day high, one day low, one day high, one day low, this kind of massive fluctuation may actually accelerate the damage process of the multi-organs that is involved, including the eye. And specific ophthalmic aim here is to improve and or maintain as much vision as possible by treating the disease process and effect in the diabetic eye. So basically, our job as ophthalmologists is to save as much vision as possible by whatever means necessary, basically. That's the bottom line. So how we do that? Well, we have the retina to deal with, we have the retina to deal with, we have the macula to deal with, and some of these can be, very complex. So here it is to be stressed that for cases, especially those with no or early diabetic retinal changes, would need periodical diabetic eye screening, and the more severe cases would require close follow-up with the ophthalmologist. Let me just go to the next slide here. Okay, so this is just an overview. We're just going for an overview first, of the management of diabetic retinopathy. So you can see here on your right and on the left, the one on the left is the goals in the management of diabetic retinopathy. The one on the right is the goals in the management of diabetic maculopathy. So main issue here is to reduce the risk of proliferative changes, which leads to vitreous hemorrhage and therefore reduce vision. So this is one of the ways that the diabetes can cause reduction in vision. So we want to reduce that risk of this happening. So that's one of the goals in managing diabetic retinopathy. And we know that the healed, broken new vessels can fibrose up, leading to fractional retinal detachment as well. So this is the second thing that we want to prevent if we can do that, especially those which can threaten the macula and therefore the vision. Now, in terms of diabetic maculopathy, is to reduce the development of a macular edema and hemorrhage, which can reduce the vision. And secondly is to maintain structural functionality of the layers of the retina and the macular region. However, if you look at this, the common goal in both diabetic retinopathy and diabetic maculopathy management is reducing the risk of ischemic progression. So we get the bigger picture first, and then we go into the minutiae of how we able to manage and help our patients. So here we have the management options. Now we are going to management options. So in diabetic retinopathy, what are our armamentarium? One of them is the argon laser PRP for proliferative stage, and in patients with poor compliance and who may default clinics, even to consider PRP at a severe pre-proliferative stage already. And basically is to reduce the risk of neovascularization and hence vitreous hemorrhage and fibrosis. So that is our mainstay in management of diabetic retinopathy here. Whereas diabetic maculopathy is basically we need to assess it case by case because they can come with different levels of complexity and different areas within the macula itself, which may warrant slightly different management approach. What we have here, our armamentarium for diabetic maculopathy is macular grid or focal grid laser, or focal laser, or anti-VEGF, for example, the ranibizumab, aflibercept, and the latest kid in the block, faricimab. And we also have dexamethasone implant in the form of Ozurdex. Iluvien is not available in Malaysia, but Iluvien is available in European countries. That is actually a much longer acting compared to Ozurdex, but they have their own issues as well. If you ask me, I would prefer Ozurdex to Iluvien. And the mechanism here, basically the anti-VEGF and the steroids, is to reduce inflammatory drive and to reduce macular edema and hopefully improving the structural maintenance, the structural integrity, as well as improving the vision. And sometimes when we arrive at the proliferative diabetic retinopathy stage, with tractional retinal detachment, especially threatening the macula, then our armamentarium will be slightly different. We would have vitrectomy available, so can do vitrectomy, delamination, and to do endolaser PRP top-up. And usually in this situation, a few days prior to surgery, anti-VEGF is preferably given to soften the fibrous tissue for the ease of delamination. Having said all this, especially when we are managing patients who have advanced diabetic eye disease, obviously the prognosis may be guarded, and as such, patients need careful counseling to manage realistic expectations. Now, regarding the more severe form of diabetic maculopathy, on top of what we have discussed, including macular edema as well as macular ischemia, sometimes in the more advanced stages, epiretinal membrane ERM may happen. And if that is the case, and if it really affects the vision, vitrectomy and ERM peel may be required. Usually the prognosis in such cases of advanced diabetic maculopathy with ERM is guarded, but sometimes we don't have a choice if we want to improve the vision, even by a little bit. And patients need to, again, be carefully counseled to manage a realistic expectations. Okay, so here we have managing diabetic retinopathy. So we are now, after we have seen the overall picture of what we can do and what is needed to achieve what we want to achieve, the objective. So let's go on to the scenarios. So the management of the diabetic retinopathy, we will go on to the maculopathy later on. So now it's retinopathy. And partly depends on the stages of diabetic retinopathy as well as the state of the maculopathy, if any. Because we cannot just manage one without the other. We have to take everything into consideration. So let's say, for example, scenario 1, there's a mild non-proliferative diabetic retinopathy with no maculopathy. So what do we do? So with all our diabetic retinopathy patients, it is important to stress that they need to continue with a good and consistent diabetes and blood pressure control, with the evidence that have been discussed in the UK PDS study, just as an example. So with that in mind, assuming that the patient is on board with good systemic control, one can consider a 9 to 12 months review in such patient. And in scenario 2, with a moderate non-proliferative diabetic retinopathy with no maculopathy, because it's moderate, can go either way, and sometimes it also depends on how the systemic control is. So we don't want to put this patient in the long leash, so we need to consider reviewing them every 4 to 6 months, depending on the logistics as well. Now, for those who, in scenario 3, moderate non-proliferative diabetic retinopathy with observable maculopathy. Observable maculopathy here, basically those without any macular edema in general. So one may consider a 3-monthly review. Of course, clinical discretion is based on experience, may be required here. In terms of deciding how frequently the patient needs to be reviewed. And in scenario 4, you have severe non-proliferative diabetic retinopathy, observable maculopathy. What will you do in this kind of scenario? Because it's a severe non-proliferative diabetic retinopathy, one more step, you'll be a proliferative diabetic retinopathy. So we need to consider a more closer observation. We could consider 2 to 3 months a review as well. But having said that, which is why I mentioned earlier that history taking is important, the social history side as well. So basically that will give us a better idea whether this patient is likely to default clinic or not. So if a patient has default clinic and HbA1c is poor control, in selected cases, we might even consider PRP in the severe non-proliferative stage already. So in scenario 5 is proliferative diabetic retinopathy. What do we do? PRP ASAP, basically, as soon as possible. And in young patients with diabetes type 1, may consider spreading over a few sessions to reduce the risk of macular edema, because that's one of the potential issues that might arise. And when doing or delivering PRP laser, it is encouraged to titrate the laser power adequately to cause light blanches on the retina to avoid overburn. The aim is for even distribution of the PRP, superiorly, inferiorly, and nasally, and temporally, and especially temporally. It's a watershed area with a bit of more ischemic drive. So, and more often than not, from my experience, looking at proliferative diabetic retinopathy patients who have had previous PRP episodes, a lot of the time you will see that the temporal area just adjacent to the macular region is more often than not is underfilled. So those areas need to be filled up with appropriate amount of PRP. So in scenario 6, we have a proliferative diabetic retinopathy and diabetic macular edema. What would you consider then? Well, one may consider PRP and macular laser if appropriate, and anti-VEGF treatment as well. So why would I say macular laser if appropriate? Is because it depends on where the diabetic macular edema is, the systemic exudates are, and basically is to try to avoid areas which is too near the fovea, basically. Yeah. Okay. So when do we need to be more concerned when managing diabetic retinopathy? Any diabetic eye changes, also any other comorbidities that can or imminently threaten the vision needs very careful attention. In the diabetic eye changes, from the way I see it, can be divided into two broad categories. The first category is treatable to improve vision. Second one is non-treatable to improve vision. For this category, we need to maintain vision as much as possible. What are the non-treatable category? That is the ischemic drive, the ischemia. When you have ischemia, it's irreversible, ghost vessels, etc. So we can't do anything. So when we see it, we just need to systematically manage it better control to prevent further damage from that point of view. So that's the only thing that our hands are tied in the non-treatable condition. So in the treatable category of diabetic retinopathy include tractional retinal detachment, especially threatening the macula of the optic disc, and vitreous hemorrhage. So these are the two main entities that we can treat to help improve the vision. Okay, now with that in mind, I have an example case for you. So a picture paints 1,000 words. So by looking at this one picture, you may be able to more or less tell the story of how the patient arrived at this stage of presentation. Anyone would like to share their thoughts on this? I know it's not a full picture, it's just the central part, but I think based by looking at the picture, it should be enough information for us to get a timeline of what the patient has encountered since starting the diabetic retinopathy until the presentation. Anyone would like to share their thoughts on this? Let me just go to the chat again.
That's Dr. Isa is also answering there, Prophet.
Sorry?
Dr.
Yeah?
Isa is answering, yeah.
Is that, yeah, okay. So let me see, where was that? Hang on a second. Yeah. So Muhammad is, okay. Patient will tell having floaters or curtain light vision. Well, yes, curtain light vision, floaters, yeah. Curtain light vision, yes. Yes, this is definitely a high risk proliferative case. And why do we say that? Anyone would like to illustrate it more?
Probably the curtain light vision is that meant for arterial occlusion, or that
I think it may be the the this vitreous hemorrhage, I think.
causing something blocking.
Yeah, blocking and causing the curtain light vision. Anyway, I'll just I think it's either you guys are shy or what, I'm not sure. But anyway, I'll go through the picture with you. So
Okay,
basically, if you look at this picture, you can see a lot of things. But let's begin with what we can see. What is obvious here is the vitreous hemorrhage. Any vitreous hemorrhage in a diabetic patient would mean proliferative diabetic retinopathy until proven otherwise. So we look for the source of the bleed, easily visible. You can see here. Can you see my cursor? Yeah, you can see my cursor. You can see the bleed is here. And you can see that this behind the bleed, you can see a lot of new vessels here. They are active new vessels. They are beefy in structures. Yeah, you can see that. And what else can you see? You can also see, you see this one? Looks like Irma to me, this one quadrant here. And what else can you see? You can see this line here, like a fibrous tissue, isn't it? Like a tractional fibrous band here as well. And in the more periphery background, you can see black dots here, which is representative of previous episode of PRP. Of course, we know this patient have heart exudates here and dot hemorrhages here, and that is just a maculopathy which happens to be there with the retinopathy. But more alarmingly is this thing here. And if you look at this carefully as well, you might even see some striae here, which may represent epiretinal membrane as well. So what is this picture telling you? Meaning to say, this is may not be the first episode of the vitreous hemorrhage. I mean, you can see there's a fibrous bands here. So meaning to say, this patient might already in the past have a proliferative diabetic retinopathy with vitreous hemorrhage past episode, which then heals up, causing fibrosis. Yeah. So the patient, when was first diagnosed with PDR, was given laser treatment, PRP, as you can see here. And perhaps the diabetes control is not very good, and maybe the PRP is not adequate. Therefore, have new active vessels, which bleeds again. So this is telling us the story of how it started until now. So so now you can see picture paints 1,000 words, in the sense that by just looking at the picture, you may already know how poor the diabetic control is to reach to this stage. Yeah. So what it means, the take-home message here in this picture is that when you assess your patient, it is important to note carefully all the signs and appreciate it, and try to correlate the sign with the history. Okay, let's go on to the next slide here. Hang on a second, let me just. So the next slide here is dealing with diabetic tractional retina detachment. So when do we consider referring to the vitreoretinal surgeon? So basically, when you see a patient who have tractional retinal detachment from the diabetes, which may be macular and or optic disc threatening, you might want to refer. For example, if you have patients who have fibrous tissue in the periphery, does not really affect the macula, and it's already non-active, everything has died out, there's no new active new vessels, one might just continue to observe. But if you feel that, if you see that the traction and things like that is actually threatening the macula or the optic disc, then obviously you might need to consider referring to the vitreoretinal surgeon for delamination as well. And the second category of patient is the recurrent vitreous hemorrhage with worsening fibrovascular traction. So with recurrent vitreous hemorrhage with worsening fibrovascular traction, it means that the control may not be so good, recurrent hemorrhage, and therefore giving you more traction and potentially more damage. So this category of patient can also be considered to be referred to the vitreoretinal surgeon for vitrectomy. The objective of this vitrectomy here is to relieve any traction to the macular or optic disc, as well as to remove the scaffold on which the new vessels can grow onto. So that is the main objective why we need to do this vitrectomy. And at the same time we do this vitrectomy, we do further endolaser, PRP as well, depending on the status of the fundus. And early referral actually can lead to better visual outcome post-op as well. So the moment you see that things are not going the right direction, feel free to refer to the VR surgeon for early vitrectomy. It actually will do more good to the patient. Okay, now let's get on to the next slide. Okay, so this one here is dealing with just now it was dealing with tractional retinal detachment. Now it's dealing with diabetic vitreous hemorrhage. So as we mentioned before, diabetic vitreous hemorrhage is proliferative diabetic retinopathy until proven otherwise. So again, vitreous hemorrhage can happen in many different forms, different severity. So let's go on with the scenario. So the first scenario is you have vitreous hemorrhage, but the fundus view is still adequate. So if you get adequate fundus view despite the vitreous hemorrhage, first of all, we need to ensure that the retina is flat, there's no tractional, and to consider PRP as soon as possible. That is the first scenario. In scenario 2, where there's no or poor fundal view, ultrasound B scan may be required to ensure a flat retina, and then to consider NTVEGF as a temporizing measure. And if the vitreous hemorrhage clears adequately from the for PRP within 1 or 2 months, then we perform the PRP. However, if it's not clearing within 1 or 2 months, maybe we need to consider vitrectomy endolaser PRP. And NTVEGF 2 to 3 days pre-op may help smoothen the vitrectomy procedure, as we mentioned earlier. And early vitrectomy in vitreous hemorrhage cases may have a better visual outcome in achieving stability sooner. I shall share a case study with you to highlight all these situations. Okay, so basically this here is just an example of tractional retinal detachment. And you can see a lot of fibrous tissue. And in fact, if you look at this picture here, there may be more than one layer of fibrous tissue, meaning to say fibrous tissue on fibrous tissue, which may suggest repeated, recurrent vitreous hemorrhage, healed up, recurrent, and healed up, therefore producing layers and layers of fibrovascular tissues which have contracted and lead to tractional retinal detachment around here. And if you look at this one, see the striae here. So basically, it means that the macula has been pulled as well and affected by this traction. And some of these cases, unfortunately, present a bit too late, which may be inoperable, unfortunately. So, but having said that, we do our best with what we can to save as much vision as possible. So basically, this here again is just another example of what tractional retinal detachment will look like. And it's due to the contraction, as we know, from the pre-retinal new vessels surrounding the fibrous proliferation. And this is just a snapshot of how sometimes a proliferative tractional retinal detachment, because of the fibrovascular tissue, is very difficult to remove as well. You can see that how sticky it is, just to illustrate to you. So sometimes NTVEGF a few days before the operation can actually help smoothen this procedure. Okay, so now let's go on to the management of diabetic maculopathy. So active treatment is required when presented with a diabetic macular edema. So why do we need to treat macular edema? Because we want to improve the vision. Okay, number one. Number two, we want to maintain as much of the structure as possible. So because a good structure means good, possibly good vision as well, assuming there's no ischemic component sets in. When no clinically significant macular edema is noted, but with microaneurysms, heart exudates, this can be considered as observable maculopathy with review 1 to 3 months, depending on clinical impression or severity. But if for those patients who have DMO, diabetic macular edema, the aim of treating it, like I mentioned before, is to maintain the vision, which is the function, as well as the structure. So what do we have in our current options available to manage the diabetic macular edema? Well, it depends on the presentation of the edema itself. We have here anti-VEGFs, bevacizumab, ranibizumab, aflibercept, and the newer one, faricimab. Macular focal grid lasers, Ozurdex implant, especially in pseudophakic eyes, or we can do a combination of the above depending on the presentation. And the choice of the treatment is dependent also on clinical and OCT findings as well as comorbidities. So I've highlighted also this bevacizumab, which sometimes I think in private sector is used as off-label as well because of, it's more economical for patients. Although I know that in government settings, they only use licensed anti-VEGF like ranibizumab and aflibercept. So this bevacizumab in the previous Royal College of Ophthalmologists of the UK have actually issued a statement that said that it can be considered to be used as off-label in view of its economic benefits. Okay, so as we mentioned before, the choice of treatment is dependent on the multiple factors, which includes visual acuity, fundus findings, the OCT findings, the lens status, and the comorbidities like glaucoma, etc., and also response of patient to previous treatment. So, for example, going to the choices of anti-VEGF in the use of diabetic macular edema, we know that from studies supported by the DRC and NET that an initial visual acuity of 612 or better with DMO, ranibizumab may be a better option with better vision improvement. And if visual acuity presenting less than 612, aflibercept may be the better option for vision improvement. Having said that, a lot of studies later on supported the fact that both have comparable benefits and comparable safety effects. And now the latest one, faricimab, which is a new medication. In our local setting, we are still gathering experience and monitoring clinical response of our patients. So as such, not much can be said for now, except that it's one of the medications that can be considered. And personally, I may consider that if the other two previous ones not being helpful. So if one is using anti-VEGF, when to switch if no improvement? So at the moment, currently, there's opinions are varying. There's no hard and fast rules, but some studies have considered that any improvement of less than 5 letters of improvement or less than 20% reduction of central retinal thickness after 3 months can be considered as non-responsive. So in cases where visual acuity is poor and in the presence of OCT biomarkers, whereby anti-VEGF can be expected to have poor response, then we may consider Ozurdex injection. With Ozurdex, we need to monitor intraocular pressure as well as cataract status if the patient is faking. And the regular follow-up with OCT is needed to monitor progress in these higher risk patients. Also, correlating visual acuity with clinical and OCT findings, function versus structure is important as well, because we need to monitor these patients' progress as a whole. And in cases where there are CSMO, clinically significant macular edema, affecting the fovea, as well as the peripheral macular region with succinate exudates with microaneurysms, if patient showed suboptimal response to initial anti-VEGF alone, may consider a combination of anti-VEGF and gentle focal or grid laser. And with that, we have to laser away from the fovea. So what other further management considerations do we need to take into account when we're managing diabetic eye disease? So it's not just the fundus, not just the retina, not just the macula, but sometimes we need to look further as well. For example, in diabetic ischemic fundus, it may lead to rubeosis and rubeotic glaucoma. As such, we need to treat that problem as well. So the treatment is same. Basically, any kind of new vessels, whether it's the back of the eye or the front of the eye, is signifying ischemia. So the treatment is PRP. That is a standard treatment. And sometimes, depending on case-to-case basis, anti-VEGF can be considered as a temporizing measure as well. And treatment is also influenced by the vitreous media clarity as well. And I'll give you examples. In rubeosis in diabetic eye disease, in scenario 1, where rubeosis with clear vitreous media and normal intraocular pressure, what do we usually can consider? That would be PRP, basically, and observe. In scenario 2, whereby you have rubeosis with vitreous hemorrhage and normal intraocular pressure, we can consider vitrectomy and endolaser. And in scenario 3, if you have rubeotic glaucoma, clear media, we can consider PRP with anti-VEGF as a temporizing measure because it may work faster, and also anti-glaucoma topical medications. Sometimes, depending again on case by case, we may consider transscleral micropulse cyclophotocoagulation as well. And in scenario 4, we have, let's say there's a rubeotic glaucoma with vitreous hemorrhage, cannot see much, no choice, we cannot do the PRP because we can't see clearly. So we need to consider vitrectomy, endolaser, and anti-VEGF as well. And sometimes in selected cases, may be beneficial to do a glaucoma drainage device or glaucoma surgery. And thankfully, a combination surgery combining both glaucoma and vitrectomy surgery is rare, but some very rarely. Personally, I have been forced to do this to help the patient, save the patient's eye the best we can. Because glaucoma, the pressure is too high, cannot sustain for a longer period of time. At the same time, vitreous hemorrhage, we need to do something. So we just have to do everything in one sitting to help this patient. But like I said, such combination surgery are rare. Okay, so with that in mind, so we have already covered management of diabetic retinopathy, vitreous hemorrhage, maculopathy, and the rubeosis. So now let's go on to a case study. This is to illustrate to you case. This one is a 45-year-old Malanao gentleman with suboptimal control of type 2 diabetes. Well, Malanao is one of the races, indigenous races in Sarawak. So he has a suboptimally controlled type 2 diabetes, initially referred by a general ophthalmologist with in 2016 with best corrected vision of 20/150, pinhole no improvement, left eye hand movement. The right fundus showed proliferative diabetic retinopathy with tractional retinal detachment involving the macular and vitreous hemorrhage. The HbA1c was 9%. The right eye on presentation had a mild to moderate cataract. So in a short period of time, I said this patient obviously need surgery. So went on to have an uneventful right pars plana vitrectomy with delamination, endolaser, and gas. Intraoperative findings showed ischemic-looking retina with macula with ghost vessels as well. So you can see that to start with, the retina is already not healthy, but to be made worse by the tractional retinal detachment as well as the vitreous hemorrhage. So the vision became 20/150 on presentation. But post-operatively, with the best corrected vision back in November, which is 2 months after the surgery, we could get the patient back to 20/40, which is 6/12 vision, which is quite good. I mean, it's still, considered as more or less driving standards in Malaysia. So it's quite good. You can still function, you can still do your work and things like that. However, unfortunately, the HbA1c continued to be high, over 8% in November-December 2016. So after the vitrectomy, his PDR, his proliferative diabetic retinopathy, remained stable with no active vessels. I think because of two things. One is we remove the scaffold. Two is adequate hand-retinal photocoagulation. So with that, the retinopathy remains quiet, which is good. So it has always remained quiet since after that time. Very thankful for that. However, he continued with suboptimal diabetic control despite repeated advice on better control and the endocrinologist input. So this led him to develop diabetic macular edema, which did not respond well to anti-VEGF and gentle focal laser. and subsequently we had to switch him to Ozurdex. Finally, the CSMO has disappeared, but the effect of the CSMO fluctuation had led to the DRIL, the drill, and the thinning, subsequently developing epiretinal membrane, and then the macula became ischemic. Vision became poor over the years to a point that he cannot perform his duties, which requires computer work. So based on this case only, the learning points from this case, what can we learn from this case here, considering the sequence of events? Early vitrectomy can lead to favorable visual outcome, and to sustain good vision, input from ophthalmologists as well as physician endocrinologists working hand in hand is important to maintain to maintain a good control of the diabetes and should not be overlooked. And thirdly, patient education, awareness, and active participation in the disease management is important to maintain the vision and health and quality of life. Now, with that, I would like to end with some multiple choice, interactive multiple choice question. I hope you guys are okay to participate. So basically, this is a bilateral pseudophakic patient with a poor controlled diabetic with HbA1c of 14% and proliferative diabetic retinopathy with inferior mild vitreous hemorrhage with central clinically significant macular edema and best corrected visual acuity of 624 on Snellen chart in the right eye. The OCT macula showed high number of hyperreflective foci. How would you treat this patient? So we have given 5 different choices here to choose the most suitable. Of course, all these are plausible management option, but which one of the 5 plausible management option would you think is the most suitable for this case? So we have A, laser PRP with ranibizumab course of intravitreal injection. 2, laser PRP with aflibercept course of intravitreal injection. 3, PRP with bevacizumab course of intravitreal injection. 4, PRP and Ozurdex intravitreal injection. And 5, pars plana vitrectomy with endolaser and anti-VEGF. Anyone would like to share your opinion? Yeah, I think I can see some response here. So a lot of people here saying it's D, which is laser PRP and Ozurdex intravitreal injection. Okay, good. Do you want to know why you chose D for those of you who have not chosen as the most appropriate? Well, obviously, first of all, the fundus is visible. So therefore, PRP is the way to go to do that. And secondly, is to choose which treatment is most suitable for central macular edema with a 624 vision, poor diabetic control, and predictive biomarkers of the OCT. So taking all this into considerations, Ozurdex is considered as, and also pseudophakic as well. So Ozurdex is the more appropriate option. So let's go on to the next multiple choice interactive scenario. It's a type 2 diabetic phakic minimal cataract patient presented with a left diffuse clinically significant macular edema with multiple succinate exudates and microaneurysms and moderate non-proliferative diabetic retinopathy with a best corrected visual acuity of 6/15. HbA1c is 7.5. How would you manage this patient? You have also 5 plausible choices of management. 1 is course of intravitreal injection of ranibizumab. 2 is course of intravitreal aflibercept. 3 is Ozurdex injection. 4 is course of intravitreal ranibizumab with gentle macular focal grid laser. And the final one is course of intravitreal aflibercept with gentle macular focal grid laser. Any thoughts on this? I think a couple of you have mentioned course of intravitreal aflibercept with gentle macular focal grid laser. Any further advancement on that? Anyone, any other thoughts? Please feel free to type in the chat. Yes, someone has written the reasoning behind, the thoughts behind, based on the evidence-based medicine. Yes, BCVA 6/15, and the presence of succinate ring, which is, and it's also it's diffuse, yeah, it's diffuse. So it's not just in the center part of the fovea, but also diffuse, which may benefit from these focal or grid laser as well. Okay, good. So just to summarize the challenges, well, patient education and awareness, especially in our part of the world, is still can be considered as its infancy. So we need to really promote patient education and awareness, and also public awareness for that matter, and also for us as clinicians to be aware and have an appropriate and timely management for our diabetic eye patient, which is vital for a more favorable long-term visual outcome. And also, because of our geographical uniqueness in parts of Malaysia, it can affect the patient access to healthcare, and that can also affect the management of diabetic eye disease in our country as well. And also, of note, the availability of resources for a successful diabetic retinopathy screening program in our community. Okay, so this is just a reference and just acknowledgement. And thank you very much for your attention.
Thank you, Prof. Lik. Thank you for the very, very insightful talk. I learned a lot from the session too. Thank you for those attendees, all our attendees. Thank you for staying with us until the end of the session. Thank you also for all the response and also questions. I hope we have answered all questions, yeah, Prof. Lik?
Yeah, I think so. I have to check the. There's no pending questions. Yeah.
But don't worry, if you have any further questions, you can always email Prof. Lim, right? And
Yeah.
email us, email me, and you know, we're more than happy to share. Now Adisa will be sharing the CPD point. Yeah, there's a announcement by the moderator for your CPD point. For MMA CPD point manually accreditation, you have to fill out the link. So do click on the link. It is valid until the 6th of February. Self-claim can also be done. If you have any question or any problem with your CPD point certificate, please feel free to contact Puan Aliza Harun, yeah? Who is actually our representative from the College of Ophthalmologists. Now, I think we're coming to the end, Prof. Lim, yeah?
Yeah.
And, is there anything else that you want to sort of, your last word probably? Anything that you wish to share?
Well, I've actually typed in my email for those who would like to ask any questions eventually in the future. So you can always email me directly with my email, which I've typed into the chat meeting.
Excellent. Thank you, Prof.
Okay.
Thank you so much
Yeah.
for that. So thank you, everyone. Gratitude to all the audience for being with us until the end of the session. I would like to just make a small announcement also to take this opportunity to invite any ophthalmologists in this webinar who has not joined the College of Ophthalmologists. Please feel free to visit our website, yeah, for more information. So before we end, can I get assistance from everyone to switch on the camera? Aliza, can we take a photo as to keep as one of our memory of the webinar? Thank you so much. Can we have all the attendees to switch on your camera? Aliza, you ready?
Yes, Prof.
Thank you so much. Okay, so how are you going to do this? Aliza, you will lead, yeah? You tell us what to do. Smile or whatsoever when you're ready. Okay, Aliza, you can.
Waiting the others to open the camera or can take now?
Do you have enough quorum? Do you have more than 60% or 70% with the camera on? Do you have enough, Aliza? Because I can't see everyone actually. Oh, okay.
Can I take now?
Yep. Hi, Dr. Paul. How are you? Okay. Smile, everyone. Smile.
Okay, 1, 2, 3.
Are you okay, Aliza? You continue smiling or what? Aliza, you okay?
Okay, one more time, ah.
One more time. Okay.
Okay, 1, 2, 3, smile.
Namanya Aliza.
Okay.
All right. Okay. Thank you so much,
Okay.
everyone. Thank you. Hope to see you guys in the future. Yeah. Thank you, Prof. Lim.
Yeah. Thank you. Thank you,
Okay.
everyone.
Bye.
Thank you. Bye.
Aliza.
Have a good weekend.
Great. Thank you.